So we are moving to next session, and it's my pleasure to introduce, and I don't need to introduce Bill Stevenson to anybody who is interested in VT ablation, because he's one of the gurus of VT ablation. As you know, he described this reentrant circuit, how you can identify different components of the reentrant circuit by pacing. And Bill will give us such a kind of overview of history of VT mapping and ablation. And there is no more, I would say, qualified person for this than Bill. So it's my pleasure to have him here.
Well, thank you very much. Is this on? You hear me? Okay. Thank you very much, Joseph. It's really a pleasure to be here, and congratulations on the 25th session of this wonderful Congress. So, VT ablation really started with the pioneering work of Guy Fontaine and Gerard Giardone with surgical ablation for ventricular tachycardia. And from that, Mark Josephson pioneered catheter mapping, and really in a series of remarkable papers in the late 70s and early 80s defined a lot of the terminology that we use and the way that we tend to now think of catheter mapping for ventricular arrhythmias. And his mapping really focused on identifying the exit region around the scar, and then the surgeon, of course, took out a very large area of scar. So when DC catheter ablation came along, invented by Dr. Scheinman and Dr. Gallagher at Duke, this was the first catheter ablation procedure, and it was going to target a relatively focal area. The first person to do DC shock ablation for VT was actually Jeffrey Hartzler, who was an interventional cardiologist who was one of the pioneers of percutaneous cardiovascular intervention. And his first patient to do DC shock ablation was actually an idiopathic RV outflow tract VT. Probably the last patient any of us would want to put a catheter in and hook up to a defibrillator and deliver a shock with the attendant barotrauma that can be produced. But the patient did well, and the field was launched. So then the question was, well, we've got this method to target a focal region of ablation. Can focal ablation interrupt VT? And there was animal work done by El Sharif and Lawrence Gessman that showed that in an animal model with large reentry circuits post-infarct, that there were critical sites where you could freeze and interrupt reentry. How do you find those? And we come back to Dr. Josephson and his catheter mapping work. And he had observed that at some sites you saw almost continuous electrical activity. And the thought was, well, if you have continuous electrical activity, maybe you're recording from the entire reentry circuit. But Pedro Brugada, who at that time was in Hein Wellens' laboratory in Maastricht, had observed that at some sites where you had that continuous electrical activity, it would come and go. And others had shown that you can have continuous electrical activity due to electrical artifact. So the question that we had as I was coming out of my cardiology fellowship and getting into this area, I was interested in working on this problem. There was a paper that was published by Doug Zipes and Eric Prostowski, in which they raised the possibility that with catheters, you could exploit this phenomena called inhibition, that if you put in a stimulus during the refractory period, it could extend refractoriness. And we thought, well, maybe we could use this to identify critical sites in reentry circuits. So in our first DC shock catheter ablation patient, we attempted to do that. We put in scanning single extra stimuli, and we actually saw this. So here's ventricular tachycardia, there's a stimulus, and it terminates tachycardia. So we thought we had found it, but we recognized that anything can happen once in the EP lab. So we tried to reproduce it, and when we repeated program stimulation, we induced a different tachycardia in this patient. We could never find another site that did this again. And we now recognize, of course, that what this is not extending refractoriness. It's really that you're capturing and inducing a wavefront that propagates out towards the exit of the circuit, but blocks before it gets there. And then in the antidromic direction, it collides with returning waves. And Hassan Garan in an animal model and Frank Bogan have shown that usually indicates that you're in the reentry circuit isthmus. So in our second VT ablation patient, we did the same thing, and we saw nothing. We didn't recognize that anything had happened during the procedure. But in going through the tracings later that night, I was looking for evidence that maybe we'd slowed tachycardia and hadn't recognized it. And we hadn't slowed it, but what we saw was resetting the tachycardia without changing the QRS morphology. And we recognized that what we were doing was really single beat entrainment of tachycardia, and Al Waldo had described the criteria for entrainment. And then when we got to our third case, we were primed. So we knew what we were looking for. We did scanning single stimuli. We did trains of stimuli. And in that patient, we were able to find a site where we entrained the tachycardia with concealed fusion. And Fred Moratti had made the same observations independently around the same time. So the entrainment mapping was launched. And then we, applying or extending from the work observed by De Backer and Hauer in explanted hearts, that you can have these geometrically complex reentry circuits and intramural components of the reentry circuit. We thought that we could exploit these pacing maneuvers to identify critical sites of the reentry circuit when you couldn't map the entire circuit. And this idea was further extended by Eugene Downer in Toronto, this idea of complex reentry circuits, three-dimensional in their geometry, and with large sheets of activation connected by critical segments of reentry circuits. Well, we didn't have any way to validate any of this mapping stuff with DC shock ablation, because when you give a DC shock, everything terminates. But when radio frequency ablation came along, pioneered by Sean Wang at the University of Arizona, and then first applied it for ventricular tachycardia ablation by Michael Davis and Martin Borgreff and Gunther Breithardt in the late 1980s. Now we had a way to try and validate mapping data because when you turned on the RF and you were at a critical spot in the reentry circuit, you would expect the VT to terminate. So we had kind of worked out what we thought should happen with pacing maneuvers in computer simulations and in people who are having DC shock ablation, and we were then able to test that in a series of patients who were undergoing radiofrequency catheter ablation, and that allowed us to validate some of the entrainment maneuvers that we still continue to use. But that doesn't address some of the other important mapping challenges for VT, particularly with scar-related VT having multiple morphologies of VT, limited mapping time that you can spend in VT because the VT is often hemodynamically poorly tolerated. So we need a different approach, and that approach has evolved into what we now are commonly refer to as substrate mapping. The first time I can find substrate mapping used in the literature was this article from Helmut Klein and Al Waldo, using it with the thought that identification of the electrophysiologic substrate of ventricular arrhythmias could be found with mapping, and they were using this during surgical ablation. And of course, John Miller and Dave Callens and Mark Josephson extended that to the use of catheter mapping in the electrophysiology laboratory. But they observed that you often saw abnormal electrograms over wide areas. It usually didn't direct you to a particular site, a critical site for reentry. And we observed the same kind of thing correlating findings of pace mapping and abnormal sinus rhythm electrograms to critical sites of reentry circuits defined by entrainment, that you often saw abnormal areas over a very broad area, and it didn't seem like it would be helpful for directing ablation to an individual site. Then came a major technological advance that really was a game changer, and that was the development of electroanatomic mapping systems. And Shlomo Ben Haim developed the first system that achieved commercial success and developed into the CARTO system. Graydon Beatty developed a system that evolved into the Abbott EnSight system. And these enabled one to define and better relate the anatomy to the electrophysiology. And then Frank Marchlinsky and Dave Callens, in really a landmark paper, defined voltage mapping. And this criteria of the 1.5 millivolts being very specific for areas of scar where myocardium had been replaced by fibrosis. And this number has held up very well with standard ablation catheters and large tip catheters. And a number of groups have validated that relationship between voltage and scar. And there's elegant work that you all are familiar with from Katja Zeppenfeld and the group in Leiden, correlating this in a variety of diseases. And also clarifying that 1.5 millivolt threshold is very specific for fibrosis, but that very often you can have fibrosis that extends underneath areas of surviving myocardium on the endocardium, which exceeds that 1.5 millivolt threshold. So it's not very specific. That has led to the substrate type of ablation approach, and one can take the approach of painting the low voltage area red, as was reported by Luigi Di Biasi and Andrea Natali, or a more refined approach of trying to identify critical channels within the scar that's been elegantly demonstrated by a number of investigators, Pierre Jay coining the term LAVA, local abnormal ventricular activity, Antonio Baruzzo with scar dechanneling, and others evoked delayed potentials and identifying hidden substrate and hidden slow conduction electrograms. And all of these are targeting these regions of surviving myocyte bundles that can be dissociated from some of the surrounding myocardium. And this is typical of areas of reentry circuit channels. You can also identify these with pace mapping, demonstrated by Professor Di Chalou and others. And we also recognize that with this substrate mapping sort of approach, that you see a lot of electrograms that are far field signals, that by which I mean they're generated by depolarization of tissue at some distance from the recording site. And there are ways of trying to identify those with pacing maneuvers and with the further advances in development of high-density mapping systems, where and all of these systems now have algorithms that attempt to do a better job of recognizing the local potential versus the far field potential, often by considering the adjacent activation of points. The development of these high-density mapping systems allowed further refinements in substrate mapping, and Elad Anter came up with the concept of reentry vulnerable zones, areas of slow conduction and abnormal conduction that can be identified by pacing during sinus rhythm, or changing the activation sequence during pacing, and showed that targeting these areas was often effective for reentry. A very similar approach was shown by Rod Tung as well. This is Rod Tung's work with the high-density substrate mapping to identify areas of deceleration zones, areas of isochronal clustering, a characteristic of slow conduction. Well, now, although substrate mapping has been widely adopted and is pretty effective, it is still useful to be able to identify a critical reentry circuit, particularly if you have a known clinical VT or a VT that originates in a high-risk area, such as adjacent to the conduction system or in the epicardium adjacent to the phrenic nerve. And the mapping systems have become so quick that it's often now possible to define complete activation over a ventricular surface for many VTs. And Paolo Della's group just recently reported that if you identify a complete reentry circuit, that circuit is likely going to be gone after ablation. That predicts a lower rate of recurrence. So there's still a role for mapping in VT and defining critical reentry circuits. But the problem is, back to the work of Drs. DeBacker and Downer, that the circuits are often three-dimensional, and in many people, components of the reentry circuit are deep to the endocardium, so that you cannot reconstruct the entire circuit with activation mapping. That brings us to the imaging, and you just heard a wonderful imaging talk. And it's quite likely that this is going to revolutionize, again, our approach to these scar-related reentrant tachycardias, as this field is moving very quickly, and a few more advances in the definition of substrate can be expected as a result of that work. So that's all on the mapping side. I'm going to leave out the huge progress that happened with the ablation tools, which is summarized on this slide. Over the last 20 years, we went from solid tip 4mm electrodes to large tip electrodes to adding temperature sensing, to adding internal irrigation and external irrigation and force sensing. And hopefully all of that work done by many of the people that you see on this slide is hopefully going to be replaced in the next few years with some other advances in technology, some of which we'll hear about at this meeting. So here's our timeline. We started in the 1980s with VT ablation. In the VT ablation registry, the procedure mortality with DC shock ablation was 4.5%. The intra-procedure mortality now with VT ablation is almost zero. It's very, very low. And we've gone from single-center observational studies and advances to now multi-center randomized trials in the world of VT ablation. But still, if you look at the recurrence rates with VT ablation, they're still in the 20 to 30 to 40% range for scar-related reentrant VT. So there's still a lot of room for progress, and this meeting's like the 25th symposium here provide us an insight into what we're going to be seeing in the future that I'm sure is going to further improve our outcomes for VT ablation. Thank you very much.
Thank you, Bill, for this nice overview. And we will make some small change because we will have live cases, and I will take Miguel to ICAM, and other guys are already in Homolka, so they will have talk from Homolka. So we will have now talk of Miguel Valderrabano on alcohol ablation, whether it will have chance to survive pulse field ablation. And then I will leave with Miguel, and Bill will finish this session, chairing this session, and all other cases will be done at distance or pre-recorded. So, Mr. Valderrabano. Yeah.
Thank you. I don't see my slides. Let me see, maybe swap this. Okay. Swap this place.
Yeah.
Got it. Thank you very much. It's an honor to be here in the 25th Prague Rhythm course, and it is my 10th anniversary here. The first time I came here was 2013, so I'm really happy that this is going and growing. And I'm humbled to follow Dr. Stevenson, and following his talk, my stuff is going to feel kind of pedestrian, but this is the way it is. So I've been tasked with the task of discussing the role of venous ethanol in ventricular arrhythmias, and to answer the question as to whether it would hold a fight against PFA. So my answer to the question is yes, I think it will hold effect. I will discuss the role of alcohol ablation in two specific contexts of ventricular arrhythmias. One is LV summit ventricular arrhythmias, and the second is alcohol for ablation of large VT substrates. So starting with LV summit, the challenges of LV summit ablation are really several of them. Number one, it's a very complex anatomy and very complex fluoroscopy to deal with. Number two, when it comes to the veins, not until recently, we did not have a clear idea of the venous anatomy of the LV summit. There tend to be multiple vein candidates, and these are best visualized when you have obviously a 3D renditions of a CT. It's easy, like in this one, you can see the LV summit veins. But in fluoroscopy, it becomes harder because you see a two-dimensional shadow of your venograms. And I just want to make a clear point, clear take-home message that if you use the LAO caudal view, you open up the transition from great cardiac vein to the anterior interventricular vein. And in that projection, it's very easy to see all the LV summit veins, which include an LV annular vein that goes towards the aortomitral continuity, a septal vein at the corner of the great cardiac vein with anterior interventricular vein, other more distal septal veins that may have branches between the pulmonary artery and the aorta, and some diagonal branches. When it comes to delivering alcohol, we also need to be cognizant of the extensive collateral circulation that exists between coronary veins. The collaterals are both epicardial, as shown here, which would be pre-capillary collaterals, and you don't want to, you want those to be closed because the alcohol will shunt from one vein to another, and then there are post-capillary collaterals. So let me just show you how this is done in an easy way. Following this scheme of the anatomy, what we do is we select a LAO extreme caudal projection that opens up this transition from great cardiac vein to anterior interventricular vein, and then we sequentially map septal veins. The septal veins will be displayed as veins that go leftward in the screen, rightward anatomically to the anterior interventricular vein. And here I have a microelectrode catheter in a distal vein where I get a signal that is 30 milliseconds before the QRS. If I map a more proximal vein, I get a signal that is 46 milliseconds before QRS. This is way earlier, greater precocity that we're used to when we map endocardial surfaces, but keep in mind we're mapping directly in the intramyocardial. And the way this is done in general, we do a 3D map, activation map of the RV and the LV outflow tract and the anterior interventricular vein. Typically in LV summit arrhythmias, the earliest signals will be in the corner between great cardiac vein and anterior interventricular vein, as shown here. We look at the veins, we map them sequentially, and then we deliver alcohol. In most cases, not all of them, when we select a vein to deliver alcohol, we inject contrast first, and we will see intramyocardial staining, which means that the alcohol would go directly to the myocardium. This is one such example. We started mapping the subaortic LV outflow tract with the catheter folded over itself, mapping the subaortic LV outflow tract, where we had a good pace map. You can see the ablation catheter tip in this intracardiac echo still picture, showing just underneath the aorta, as shown here. And then we mapped the great cardiac vein, and we put a microelectrode catheter in that corner. We had delivered radiofrequency in the subaortic area, just to be thorough. And when we look at the fluoroscopy and we identify the intramural vein where we have the intramural microelectrode catheter, we have a signal, again, 39 milliseconds before the QRS. And when we inject contrast, you see there's some collateral flow, but there is myocardial staining. So in situations like this, what we do is deliver alcohol. And what you will see is an immediate increase in echogenicity in the area that's being ablated. Here I have side by side the location of the ablation catheter tip when we deliver radiofrequency endocardially. And next to it, the area of echogenicity that developed after giving alcohol. You can see how it's directly intramyocardial to where we had been ablating in the subendocardium with the ablation catheter. We can, on cartosound, select these echogenic areas and incorporate them into the map. And what you will see is this beautiful colocalization of the echogenic area post-alcohol with the areas where we had been ablating subendocardially, showing that we really are delivering an intramyocardial ablation. And when you get an MRI in the first 48 hours, you will see this phenomenon of microvascular occlusion. which is the opposite of delayed enhancement, is hypoenhancement. The capillaries are blown up, gadolinium does not get there, and it looks dark. Some cases are not like this one where we have staining in the first injection, and some cases require advanced technique to deliver alcohol into the myocardium. And we published a series of such kind of advanced techniques to deal with more complex anatomy. I will go quickly over some of them. This is one example of the technique of double balloon approach to limit distal flow. So this is a case where similarly we had mapped the LV outflow tract, and we had mapped the anterior interventricular vein, and we had an octapolar catheter in the first septal branch of the corner between the great cardiac vein and anterior interventricular vein. Our signal was best 39 milliseconds before the QRS, not in the distal electrode, but in the electrodes 2, 3. So we did not want to necessarily target with alcohol the more distal aspect of this septal vein. When we look at the venogram of this septal vein, you see how it's a large septal vein in the LAO choral view, and in the RAO view, you see how this septal vein continues and has a long branch inside the septum, but we do not want to target. The multipolar electrocatheter was in that vein, and the best signal was in 2 or 3, so we did not want to go beyond this area. So what we did is we put 2 balloons, one for blockade of flow, and the balloon number 2, the distal one, and the proximal balloon to deliver ethanol in that restricted portion of the intramural vein. So this is the way it looks. And when you do an MRI, in this case, we did not have a post-MRI within 48 hours. This is a 1-month MRI. You see the localized area of delayed enhancement, consistent with a regional localized scar area. There are times where you need to use the double balloon to block collateral flow. And this is one such example. This is a patient that had a large left ventricular annular vein, but the best signal was actually recorded from a septal branch of the great cardiac vein AIV junction. So there was a septal branch that kind of took off from here and communicated, as you can see here, with the annular branch. So giving alcohol here would have simply shunted the alcohol back to the coronary sinus and not delivered an intramural ablation. So what we did in this scenario is we put a second wire in the annular vein, have a first wire in this first septal, we put a balloon in the annular vein to block collateral flow, and then deliver ethanols to the balloon in the first septal. You can see now we get staining regionally in the area that we targeted without shunting back to the coronary sinus. Sometimes we've used a crossfire approach with multi-vein ethanol injection in patients that had more than one vein where we had good signals. So again, this is a baseline venogram, annular vein, and then septal. And we actually put 2 microelectrode catheters in the respective veins, first in the annular vein and then in the first septal. And when we first injected contrast through a balloon in the first septal, we saw, similar to the previous case, shunting back. So what we did is we put a second balloon and delivered alcohol through both. This allowed the creation of an echogenic area that was positioned in the area that we were targeted. These are the signals that we recorded from both intramural multi-electrode catheters, and this is the microvascular occlusion obtained within 48 hours of MRI. Sometimes the collateral circulation gives us opportunities to deal with complex anatomy. This is one example where there was a large annular vein, very big, and then followed by a first septal more distally. The best signal was recorded very proximal in this annular vein, and my colleague actually delivered radiofrequency in this area without an effect, thankfully without any damage to the coronary arteries. But we still had to deal with how to tackle delivering alcohol in this large septal vein and trying to restrict it to the very proximal aspect. These are the signals that we recorded from the microelectrode catheter in this annular vein, 38 milliseconds before the QRS, good pace map. And what we did, kind of by chance, was we advanced a wire that went from the first septal backwards through collateral towards the annular. So these arrows indicate the direction of the wire. The balloon is here. The balloon lumen is facing the coronary sinus. And what we did is we then inserted of course we paced from the wire, we got a perfect pace map. Then we put a bigger balloon in the coronary sinus blocking the flow and delivered alcohol through the balloon that was in the septal vein into the annular vein backwards, restricting the staining and the alcohol to that area and achieving therapeutic success. Sometimes we've had to deal with situations where we could not use two balloons for technical reasons or for reasons of availability. And we use this approach of venous sclerosis of large veins with prolonged ethanol dwell time, giving the alcohol for a long time. So this is one example where the patient had a large diagonal vein, the AAV was big, and this septal one was where we had the best signal right at the corner between great cardiac vein and anterior interventricular vein. Again, my colleague delivered radiofrequency thinking that it would take care of it. It didn't, and what it caused is occlusion of the AAV. So this is a stump of the anterior interventricular vein after radiofrequency was delivered. This is a problem that can happen when you deliver RF in coronary veins. The veins shut down. So now we had to deal with the problem of delivering alcohol into this first septal without an AIV, which was fine. We were able to cannulate it with a wire. But when we injected contrast, there were extensive collaterals going back. And I could not put two balloons. It was too small. So what we did is we injected the alcohol. Alcohol had been used to treat varicose veins in the past. There's plenty of literature for that. We let the alcohol sit there to 2 cc's, let it sit there for 15 minutes. And when we shot contrast, after the prolonged dwell time, we no longer had this collateral flow, and the staining was regional, was localized to this area, and we achieved success. And in case two, a very similar example, baseline venogram, two septal veins, very big AIV. They delivered radiofrequency, and now they caused a big stump of the AIV. And when we injected contrast in the septal, look at the massive collateral flow that had developed after the AIV occlusion. So again, to prevent alcohol from just simply going from one vein to another, and to force the alcohol to stay regionally in that area, what we did is we did the prolonged dwell time. And after that, the injection led to local staining and no longer collateral flow. So this can be helpful in some cases. We did a systematic study of quantifying to the extent that we could with ICE, and you're looking at the echogenic area, and with MRI looking at the enhancement on 30-day MRI to look at the extent of a scar after LV Summit ethanol infusion. You can see it. These are 10 examples of baseline and after alcohol echogenicity. You can see discrete areas of echogenicity develop in the areas that we were targeting, and we can outline it on Carto and calculate the volume. And on delayed MRIs, so 30 days or more, these are the echogenic areas, the delayed enhancement areas segmented in 3D models to compute the size of the volume of alcohol-induced scar. Overall, a median of 4 cc's, calculated by both MRI and ICE. And what we did also define is the long-term progression of the scar. These are examples of the microvascular occlusion shown in 1 day post-alcohol ablation, 44 days, and 122 days, how this area progressively becomes conventional scar, like you would see with any other kind of scar processing and a delayed enhancement area. So from microvascular occlusion to delayed enhancement chronically. These are more and more examples. Problem with this is that most of these cases had received concomitant or previous RF ablation. So we do have a couple of examples of alcohol-only ablation. Let me see if I can show this slide because I have it hidden. Yes, so alcohol, these are two examples of alcohol-only, and the same phenomenon was shown where we had 1 day post-alcohol microvascular occlusion and 41 days delayed enhancement. So it's not something that's specific it's not specific to ablation, but clearly in the absence of radiofrequency, we get the same phenomenon, microvascular occlusion followed by delayed enhancement. So these are the available evidence that we have collected over the past few years on the role of venous ethanol for LV Summit arrhythmias. We've delineated the venous anatomy of the LV Summit, the importance of the LAO caudal projection, the importance of mapping multiple veins, the role of collateral flow, large veins, and suboptimal transient response, and the techniques to deal with those, including double balloon, crossfire, prolonged ethanol dwell time for venous sclerosis. And we have delineated the real-time increased echogenicity on ice and the long-term characteristics of the alcohol-induced scar on MRI. Overall success has been 76% at 1 year of follow-up. In all of these were ablation failures. So none of these were de novo cases. All of them had a failed radiofrequency. So this is the available evidence for alcohol in LV summit. What is the available evidence for pulse field ablation in LV summit? This is it. So we'll move on to venous ethanol substrate ablation. The idea is based on the same principle. We know that alcohol delivers ablation. The idea is we need how to deliver it to large substrates. And the concept is illustrated in this figure where you have a scar that has its venous return, and you can use the veins along the epicardial aspect of that scar to deliver alcohol, most of the time using restricted alcohol delivery using double balloons, blocking distal flow with one balloon while delivering ethanol in the proximal balloon. And using, as shown here, sometimes multiple veins. We recently compiled a series of 44 patients. The idea was first to do the standard of care, which is mapping endocardially and, if possible, epicardially, and deliver radiofrequency as needed. And when radiofrequency failed, we would perform coronary sinus cannulation and venograms, find veins in the substrate of VT, map them, and then deliver alcohol using the double balloon approach. So let me show you examples. This is a case of a previous infarct due to a large right coronary artery infarction leading to an inferoseptal scar that extended to the inferolateral basal LV, and 2 VTs were induced, one consistent with a more lateral exit and one consistent with a more septal exit. What we did after delivering extensive radiofrequency was to map the veins and superimpose the veins, the vein anatomy onto the endocardial map. This is the posterolateral branch, this is the middle cardiac vein, and this is the coronary sinus. We see that the scar is between the middle cardiac vein and the posterolateral vein. These are the signals that we mapped, putting a microelectrode catheter in the posterolateral vein, late potentials on paced rhythm, and during VT mid-diastolic signals. So clearly, the segment of this vein from here to here, you could consider it as being part of the circuit, or part of the substrate. So this is the way it looks on a venogram. And the challenging part was that the vein in the scar is from here to here. And there are 2 large branches distally that we did not want to deliver alcohol into. So what we did is we put 1 balloon in each of those 2 branches, balloons 2 and 3, and balloon 1 was used to deliver alcohol proximal to those. And we did it sequentially from distal to proximal, moving the proximal balloon towards the ostium of that vein in different steps, so that we would deliver alcohol along the vein that was in the segment of the scar. This eliminated the lateral VT, but the proximal VT was still going on, And what we did then is we cannulated the middle cardiac vein, and with 2 balloons, we delivered alcohol from distal to proximal using the same approach. You can see these septal perforators going up, and alcohol would be delivered sequentially from distal to proximal into the septum. You would see echogenic area developed on the septal aspect, as well as an echogenic area developed in the more inferolateral aspect. When you sound those areas and you incorporate it into the map, this is what you see. The double asterisk is the inferolateral scar delivered, achieved with alcohol injection in the posterolateral vein, and the single asterisk is the more septal scar achieved with the middle cardiac vein. This led to led to success in eliminating induction of the tachycardia. We've done this in LAD infarcts as well. This is another example. We mapped epi and endocardially this VT that appeared to be coming from an apical infarct. The patient had not only LAD disease, but also circumflex disease, a posterolateral, a lateral scar. Everything was ablated to the extent that it could be ablated. There was no capture, pacing the endocardium. We ablated epicardially as well. This is the inside-out epicardial map. And the patient still had VT induced. So what we did is we mapped the veins that kind of collected venous return from the apex. And three veins actually got there. The middle cardiac vein had a branch, the anterior interventricular vein, and a lateral vein served venous return to this scar. So what we did is sequentially deliver alcohol in each of these. So this is the lateral vein, which the distal part was in the scar. We put a balloon in the lateral vein and deliver alcohol through this. Then we go into the middle cardiac vein, deliver alcohol in the more distal aspect. And then finally, in the anterior ventricular vein, which kind of sclerosed, as you can see here, we managed to get the balloon there and deliver alcohol. And this actually is the one that actually took care of business, causing this new area of echogenicity in the apex and eventual success. So it is a labor-intensive procedure, and you may need to tackle more than one. This is an example in a circumflex infarct. The process is very similar. Basically, different veins in the substrate were ablated, including a lateral vein and then a middle cardiac vein, and sometimes smaller veins that appear when you take multiple venograms. It also works, let me just skip this. It also works for non-ischemic substrates. This is one example of sarcoidosis, a patient with 2 previous ablations that had failed. We mapped the endocardium. The patient had a large anterolateral or basal anterolateral scar. We obtained 3D matrix in the anterior interventricular vein with a decapolar catheter, so we know the location of this vein. We ablated endocardially, nothing was achieved. We then mapped the epicardium, and there was corresponding scar in the same location. We mapped the propagation of tachycardia in the endocardium. It appeared to be, we don't have a complete re-entrance circuit. The vein seems to be completing some of the circuit. You get an idea there may be some incomplete re-entry because we're not mapping stuff that could be connecting from here back to here. So what we did is, okay, if we had a vein along this area, on the scar, it would be nice. So we performed a venogram. We had the decapolar catheter in the anterior interventricular vein, which was here. And sure enough, there's a nice diagonal branch. So what we did next is put a multipolar catheter in that diagonal branch, as you can see here. And we superimposed it in the 3D map, and you can see this octopolar catheter in the diagonal vein is right on top of the scar endocardially and epicardially. So then we look at the signals. In the diagonal vein, we had beautiful mid-diastolic signals, very robust, much larger in amplitude than what we had mapped simply in the epicardium. By pacing, we confirmed that entrainment maneuvers supported the idea that this was in the re-entrance circuit with short post-pacing intervals. And then we delivered alcohol sequentially by putting 2 balloons in this diagonal vein, from distal to proximal, delivering alcohol from the proximal balloon and blocking the distal flow in the distal balloon. And in several stages, we deliver alcohol sequentially to achieve myocardial staining. We were able to put the octopolar catheter back in the vein and showed elimination of the local signals. And by ice, we had new echogenicity that when we incorporate into the map, it matched the location of the targeted areas. Sometimes the anatomy is tough, and it doesn't allow you to complete the double balloon approach. This is one such example. Another patient with sarcoidosis and previous ablation failures, extensive epicardial scar, not so much endocardial, but you can see here the location of the anterior interventricular vein and the great cardiac vein. We were able to put the octopolar catheter in the AIV as well as in the diagonal vein. By activation mapping, it appeared to be focal. And then we basically defined that we kind of wanted to deliver ablation therapy through the diagonal vein. And we obtained venograms, and sure, there's a nice diagonal vein, but notice the presence of this big posterolateral vein that fills with collaterals. We mapped the diagonal vein with an octopolar catheter. Pace map was decent, not quite perfect. We put 1 balloon. We were not able to put 2 balloons in this diagonal vein because the balloon would not go, just because of the tortuosity and the complexity. But what we did notice is, we could capitalize on this collateral flow. So following on techniques that Seth Worley has developed for left ventricular lead delivery, we put another sheath in this posterolateral vein, a balloon and a wire going through this posterolateral vein through collaterals into the target diagonal vein. We put a second balloon in the anterior interventricular vein, and then when we then deliver contrast, you could see how we could deliver contrast through this balloon, achieving localized staining of the myocardium and no more flow into the anterior interventricular vein. And after delivering alcohol, you get this more myocardial staining. We deliver alcohol, we achieve a nice ablation, and the goal was achieved of controlling the tachycardia. So these are examples of how this was done. And similar to what we had done on LV Summit, MR can illustrate some of the mechanisms of how this works. These are, again, most of these cases have had previous ablation and complex MRIs to interpret, and many of them have ICDs. So the MRI data is not that great, but this is a case that had circumflex infarct with some subendocardial delayed enhancement, and patient underwent extensive ablation with RF plus alcohol ablation in coronary veins. We had the microvascular occlusion in the first day after the procedure in different slices here from base to apex. And on 5 months post-ablation, most of the areas have become conventional scars by gadolinium enhancement. In a case of non-ischemic VT, similar story, a pre-existing basolateral scar. After alcohol, you get this microvascular occlusion that on 1 month follow-up MRI becomes not completely, some residual, but becomes largely delayed enhanced conventional scar. Over the course of the experience of 44 patients, we showed that freedom from VT recurrence was 73% at 1 year, and you could think that most of these failures are actually due to substrate progression rather than procedure failures. The number of VT episodes dramatically decreased, not everyone, of course, and the complexity of antiarrhythmic therapy was significantly decreased. We don't have any such clinical data for PFA in humans with VT, although the experimental data appear promising. So we concluded on this experience that intraprocedural substrate ablation by venous ethanol exceeds that afforded by conventional ablation, both endo and epi, and this led to reduction on VT episodes, simplification of the antiarrhythmic therapy, and with the caveat that multi-vein, multi-balloon strategies may be required to achieve a thorough substrate ablation. This is now the content of NIH-funded Velvet trial, which will be starting hopefully soon. So to answer the question that Joseph posed me, will venous ethanol have a chance against PFA? Venous ethanol has several pros. It's a reliable bailout approach. The technology required is simple. It's angioplasty balloons that are available already, and it's cheap. FDA approved alcohol in 1946. So really, there's not much to it. But it does have also mechanistic opportunity with venous mapping, venous cannulation, perhaps understanding more of the mechanisms of VT by getting signals from the veins. The cons of venous ablation is that it's technically demanding, and PFA promises to be very simple. So far, we don't have a lot of reproducibility proven on this technology. We have no randomized data, although it may come back after the Velvet trial is completed. And it requires additional skill set that is we don't have, most of us, that we have to kind of grow and learn as we embrace this technique. And it has zero industry support, so no careers will be catapulted with this, and there's no commercial hype with it. And I'll stop there. Thank you very much.
Thank you very much. Dr. Valderrabano is going to be running to the EP lab to show us for one of the live cases. So our next speaker, I believe, is Elad Enter. Right?
No, it's me.
We've had a little schedule switch.
No, it's not Elad, me.
They will be
Is it Fermin?
with us to
Oh, great. Okay, so our next speaker then is Fermin Garcia, who will talk to us about intramyocardial mapping of ventricular premature depolarizations via septal venous perforators. Fermin.
Hello. Can you guys hear me?
Yes, we see you and we hear you.
Perfect. And you see my slides, or you see me? You see me, but there you go. Okay, perfect.
Now we see your slides.
I'm going to try to do a follow-up to Miguel's talk, essentially, because we're going to be talking about similar things but different approaches. And in a way, It's how we got here. So the area that we are discussing here, and Miguel was discussing, is the top of the left ventricle, which Chief very nicely described this morning. What we need to do when we're talking about this area is we need to understand all the kind of neighbors around the top of the left ventricle. Traditionally speaking, the LV summit is a term that was acquired by McAlpine as the highest point of the epicardial surface of the left ventricle. So that's all LV summit is. It's this yellow arrow right here. Now you can see that as you go more septal, you're on top, directly opposite to the septal leaflet of the right the pulmonary artery. You're in front of the right-left junction, and epicardially, you will below the left main, the LAD, and the fat pad of the artery. So this is why epicardial ablation doesn't really work for this. Now, what you can also see is there's some septal arterial perforators, and because the veins tend, in some cases, to follow the arteries, you get some venous septal perforators in the whole muscle. The problem is that they're completely random and unpredictable compared to that. So if you were to map this area, you have to think on the epi somehow. You can approach it from the top of the left ventricle and the left coronary cusp. You can approach it from below the left coronary cusp in the left ventricular outflow tract. Or you can use the venous branches and the potentially the arterial branches. The first experience for this, I think Chief and his team described mapping the arterial branches of the LAD for this region. You can never forget the pulmonary artery and the septal pulmonary cusp, because as a vantage point for ablation and potentially bipolar, right here you're opposite to the LV summit. And you can see it in multiple different views. And finally, in this beautiful transillumination, you can see the left coronary cusp, but right in between, you have this window being the right-left junction. And the right-left junction puts you right opposite from the endocardial aspect of this region on the LV summit. So you have kind of 6 points of attack for this. I'm going to concentrate on number 4, which is the venous mapping on how to approach this. So what we normally do, and we get access into the coronary sinus, and then access into the great cardiac vein, and then access as high as we can with a steerable sheath. And then the idea of the steerable sheath is that it's big enough that you can fit more than one catheter for mapping, and eventually you can change for an ablation. And you have to do a good venogram. I normally just put the wire that comes with the vein, and then you just do a good venogram by injecting pure contrast and not really diluting it. You can also do a balloon injection, but what you're looking for is a definition of branches. This is the AIV and the great cardiac vein. So if you put something here, you're going to be mapping the epicardium, and then here you have the venous perforators, first, second, etc., depends how they come. And the idea then is to somehow map the veins. You have to, in most cases, selectively cannulate them, and I prefer to use glide cath from Terumo because they're friendly with the veins. The JR4s and all the other catheters are really designed for arteries, and sometimes they are a little rough on the veins, and what happens is you can dissect it and you lose the opportunity to map it. Nothing bad happens, but you lose your opportunity. And here is a selective venogram of one of the septal perforators, and you can clearly see how that vein goes down the septum. It's a huge vein with a huge territory, and that has to be taken into consideration when you're going to do any strategy here for anything else. In terms of mapping, what we have been using, we started with a wire. You can use any wire connected in a unipolar way. And then we've been using lately this Japanese company distributed in the US by Baylis. It's a octapolar 2 French catheter called the EP Star, and then give you the ability to place. You cannot place this catheter on its own. You need to selectively cannulate. And the whole idea of this is for anything that looks outflow tract that is not typical RVOT. I don't even spend time trying to memorize algorithms. This is not typical RVOT because the transition is too early and it's inferior access. So you call this an LVLT PVC or presume LV summit PVC, however you want to call it. You do your venogram, and then you find the veins you want to map. You map the epi by putting it on the AIV and the gray cardiac vein, and then you find the branches that could be of interest. And what you're looking for is to see what's happening. Now, one interesting observation that I will bring up is that frequently I have seen in this region areas of late potential and fractionation. So even though these patients, most of them have idiopathic PVCs, you could argue if there is something very small happening in this muscle, because in most instances you will see these EMs are not normal. And then you're looking for the patterns of activation during the PVC. So you can look at sinus and you can look your PVC. And then, of course, it could be early inside deep on the septum, it could be early subepicardium, or you can basically find things like this that bracket this. And then you can transform this into any sort of activation mapping or to get an idea. I'm going to describe what I think is a practical approach to this, and we've been talking about this for a while. Essentially, you start with LV summit, presumed problem, and then you map the endo, the epi, and the septal branches very fast. With this information, you're going to try to look at the patterns of activation. The easy pattern of activation that I will not spend any much than 2 seconds on it is if you find something that's early in the endo. This is something that you would say, I don't need any of what you're saying, Fermin, because I go to the endo and I find it's early. And this is, again, the pattern of activation when you put the epi catheter. This is the mapped in the AIV. It's late. You can see here the wire, in this case was a unipolar wire. It's earlier than the epi. But truly, when you put your ablation catheter opposite to this, you have to think this as a unit. You're mapping the epi, you're mapping the intramural space, you're mapping the endocardium. And here you find that's early in the endo, you ablate in the endo, and the problem is eliminated. The second group of patients is, I'm hearing someone talk, I hope you guys are not. The second group of patients are the patients that are early in the epi. This is what Miguel probably was talking about when he talks about LV summit. This is what we call LV summit. This is something that's early in the epicardium. And this, of course, if you get something in the AIV that's minus 45 milliseconds, then you're at true LV summit. And that's where you have to do some techniques to figure this out. This is a classic example in which ablation catheter placed in the AIV to map the veins here was earlier in the epi than in the endo. And usually your pace maps are terrible in the endo, but they're pretty good on the epi because you're very close to the source of origin of the arrhythmia. And usually you're limited by the coronaries and the fat. We came up with this strategy that since 2000 and early 2010 or so, we look at the distance between these two catheters. And it's very simple. If you're close enough to something, you can ablate from the endo and you may reach it. So if that distance is, I would say, 1 centimeter, you may get lucky. So this is a classic activation pattern of a subepicardial origin in which is early. You can see the catheter that is set up in the first septal perforator. It's proximal to distal. That means the subepicardial is coming down to the intramural space. And we put the catheter opposite to the earliest side. In this case, it's EP star 8, not 1, because 1 is late. 1 would be here. And you can see how late we are in the endocardium. The ablation is super, super late. However, when you look at intracardiac echo, it's very useful. You have a good catheter position right here at the base of the left ventricle, and you can even see the EP star on eyes. And then you're doing a lesion, and that lesion seems to be pretty good. And the PVC goes away, but it tends to come back. Now, when it comes back, if it comes back, you have to look at the morphology. You can see here the morphology change. It becomes more right bundle and wider. So in that case, we have to redirect our attention. In this case, we use the technique of putting the ablation catheter in the AIV. And in that case, you see an early signal here. And if that distance is less than 1 centimeter from the vein to the endo and you're far from the coronaries, it doesn't matter what technology you use, you're always going to see this little ditch because your catheter is going into that first septal branch. It just cannot advance because it's too small. And then from there, you solve the problem. The third pattern is a very interesting pattern. And I think this is where I would defer that everything is alcohol. Because it's true for the true LV summit, alcohol might work much better than anything else. But in this pattern, I think that we still have a very good chance of ablation. That is the pattern in which the intramural space is earlier than anything else. So in this example, we have a patient with a PVC, and you can see here that 3-4 is the earliest activation. And when you do the activation or the propagation, on this case, the earliest is intraseptal. From the intraseptal goes to the epi and then goes to the endo. So if you put the ablation catheter simply fluoroscopically opposite to the earliest side, so 3-4 in this area, you put the ablation catheter here, the signal you would get from the endocardium is extremely, extremely late. You would not normally ablate there. But just simply because you're opposite anatomically to the side of earliest activation, and you put your ablation catheter there, now the distance, you can see here beautifully, the tip of the EP star is right inside of the septum, right here. The distance from the endo to that is 0.5 millimeters. So what happens is you're so close to the earliest side of intramural activation that if you do a lesion, even being late, your proximity is so close. You can see here from the earliest side on the vein to the endocardium, your proximity is so close that a lesion in the endo is going to reach easily the mid portion of that intramural space, and the PVC is going to go away. So I think that not everything is epicardial, and we failed because we were not doing necessarily the best work at mapping. So I think the key for success is better mapping. And you have to come with a strategy based on the pattern of activation. And my strategy is that if it's early in the endo, you ablate in the endo because that's very, very logic. If it's early in the intramural space, from the intramural to the epi or from the intramural to the endo, you found a true intramural site, then you put the catheter opposite to the earliest site in that intramural space. And because the distance is going to be way less than 0.5 millimeter, an endocardial lesion is going to ablate, and you don't need anything else, and the case is done. However, if you're subepicardial, that's where you're going to have to get to your toolbox and decide if the distance is less than 1 centimeter, you might try ablating the endo to reach the epi. But truly, here's where you're going to have to either consider ablation in the AIV and the gray cardiac vein if you can overcome the anatomical limitations and or the impedance, and or think on what was mentioned earlier today, bipolar ablation, or these are the cases that I think alcohol is going to be another very useful technique. And in rare cases, which we have no patients refer for this, in the group from Chicago, when Rod was in there, they did some thoracoscopic surgical procedure to get to below the LAD, but I think that alcohol will take away the place of any potential surgical ablation. I thank you very much for the opportunity once again to speak to you, and I appreciate the chance to be here. And I pass the computer, I think, now to Elad, who is going to come to do the second talk. We're doing the questions after, right?
Yes. Yes, we'll do questions after. I hope you could hear the applause.
Yeah.
So our next speaker then is Elad Anter.
All right. So this is what I want to do.
Hi, everyone. Can
Fermin,
you see
I
me?
think you're still live. Can we switch the audio to Professor Anter, please, from Tel Aviv University?
Okay, I think you can see me, right?
Yes, we can see you, and we see your slides.
And you can hear me too, right?
Yes.
Okay, so I was tasked with speaking about will pulse field ablation change the results of catheter ablation for VT? We can make it a short a short talk and we can say no now, or that we can go through the slides. What do you prefer, Bill?
Let's go through the slides.
Okay. Okay, so let's review the potential advantages of PFA for VT. So obviously there are safety advantages that actually fueled all this PFA. No esophageal damage, but it's not really of major significance for VT ablation. There is no or just transient phrenic nerve injury, which can be an advantage. Safer around coronary arteries, that was the initial promise. Is it really safe around coronary arteries? So let's see this paper from Vivek and Peter that looked on the Farapulse catheter for doing PVI and CTI. For PVI, it was absolutely safe. For CTI, when you systematically do right coronary artery angiography, I think in 100% of the cases, they saw severe narrowing, even without ST elevations and without clinical manifestations, but you saw this diffuse narrowing. When you gave, 1 second, sorry.
Could you swap displays because you are showing...
Oh, sorry. So how do I do this? Let's see. How do I swap it? 1 second, guys. You can see the slides, right?
We see your presenter view at the moment. Now we see the slide.
Okay, I'm sorry. You can see the slides now, right?
Yes, we see the slide.
Okay, so I'm sorry. I'll just go back one slide because I'm not sure where you lost me. So we said that from the safety standpoint, the safety around the esophagus is less meaningful for VT ablation. The safety around the phrenic nerve is important. And we spoke about, is PFA really safer around coronary arteries? And I showed this slide from Vivek and Peter's study that showed that when you do CTI, so basically when you apply PFA very close to a coronary artery, in this case it's the RCA or the PDA, you cause, in 100% of the cases, you cause diffuse narrowing of the blood vessel, potentially from spasm, because when you treat the coronary arteries or systemically with nitroglycerin, you can prevent this injury from happening. And the conclusion from this paper was that PFA very close to the coronary artery can cause acute severe coronary spasm, but that can be relieved with prophylactic nitroglycerin. But this is an interesting study that came from Ed Gerstenfeld group, where in swine, they ablated really on the coronary arteries epicardially, and they survived the animals. And what they saw there, yes, there was moderate to severe acute coronary spasm, but also there were chronic findings in the coronary arteries in the sense of mild stenosis and neo-intimal hyperplasia. And it replicates what we saw with the different technology in our animal lab. A week after ablation, there was neo-intimal hyperplasia. So I do think that that's a real phenomena. So it's not just vasospasm. There is actually actual injury to the blood vessel. As far as efficacy advantages, so one of the promises of PFA that it allows to make faster applications and potentially faster procedures. Let's see if it's really true or not. So I want to share with you some of our data when we looked with the Sphere 9 catheter on the effect of repetitive applications in the same location. And what we saw is that when you apply 4 applications, one after the other, but we wait 10 seconds between applications, you get deeper lesions and a higher likelihood of transmurality. You can see that when you apply 4 applications versus 1 application, the lesions are deeper. The volume of the lesion is bigger. But let's see what it takes. So 4 applications, 5 seconds per application. We have 10 seconds time interval between applications. Now the 10 seconds, I don't know if the 10 seconds is accurate. That's what we've done. When we waited 5 seconds between applications, we did not see the benefit of repetitive applications. So it looks like you really need to have a longer inter-application interval. Is it 10 seconds or maybe it's 8 seconds, but it's still a significant amount of time. So if you do four applications of 5 seconds and you wait 10 seconds between the applications, so in each site you're going to spend 50 seconds. Now, Ed Gerstenfeld published data with the Farapulse catheter when they did also 4 applications, 2.5 seconds between applications, also 10 seconds between applications. So that takes you to 40 seconds. So for each location, 40 seconds. We don't have data yet with the PFA from a focal catheter, but I think that it's going to be longer duration than the other two because you apply less energy because of the higher current density from a small tipped electrode. So application duration, at least currently with the first evolution of PFA, is not a big advantage over RFA. But what is really an advantage is the effect of PFA in scar. And I want to share this study that we did. In swine, we induced LAD occlusion for 3 hours, survived the animals for 6 to 8 weeks, and had an anterior wall infarction. Now, in half of the animals, we did the ablation with the Sphere 9 catheter using PFA. And in the other set of animals that had the same MI, we ablated the border zone with STSF. So it's not an exact comparison because you compare a large foot electrode catheter with a 3.5, but that's what we were able to do back then. And so the setting we used for the PFA were what we found that gives us the maximal lesion depth, which was the 4 applications, 10 seconds between applications. With STSF, we used 30 watts, contact force of 10 to 20 grams, and an AI of 700 to 800 units. Now, you can ask me, why did you use 30 watts and not more? And I want to share this with you because it's important. This is under review. But what we did a study that asked the question, what is the, first, like, is AI as a formula, is it valid for ventricular ablation? And what is the target AI value to get the maximal lesion dimension? And what we found is that in healthy tissue, healthy ventricles, an AI of 700, you can push it to 800, but overall 700 gave us the deepest lesion. Beyond this, there was no growth of lesion. But importantly, what we found is that when you achieve this AI value with different parameters, you get different lesions. So when you apply, when you get an AI value of 700 with 30 watts, you get a bigger lesion than you would get if you reach this AI value with 40 watts. Now, you'll ask why. The reason is that it's the proportional significance of time and power in the formula, and I'll show you the formula in a second. But when you apply 30 watts, the ablation duration to reach 700, or the goal AI that you have, is much longer. And when you make deep lesions, likely the duration plays a significant role. Similarly, when you apply 25 grams of force versus 15 grams of force, guess what? The lesions are going to be bigger with 15 grams and not 25 grams. And I think that, again, this is because of the formula that gives less proportional significance to time than it gives to contact force or to power. So what works in the atrium may not work in the ventricle. But to the results, when you compare the effect of PFA and RFA in scar border zone, you can see that with RFA, with this specific catheter, you get punctate lesions. They have a non-transmural effect. With the PFA and this larger footprint catheter, you get wider lesions and deeper lesions. If you quantify it, so you can see that the lesions are deeper. the depth relative to the wall thickness is also greater. The lesion is obviously wider because the footprint is bigger, and overall the ability to reach transmurality was higher with the PFA with this catheter compared to the RFA. Now, again, you can't really compare apples to oranges here, but what you can compare is the effect on the architecture of tissue. Now, with PFA, when you put the catheter on the surface and you have subendocardial surviving myocardium that is marked here with the green dotted line, obviously you're going to have an effect on this. Then you have a subendocardial fibrosis, and underneath the subendocardial fibrosis, you have mid-myocardial or epicardial surviving myocardium. With PFA, the electrical field can reach beyond or deeper than the layer of collagen to have a non-reversible effect on the deeper layers. It also, like PFA does, it doesn't affect the nerves in the collagen that it reached an effect deeper to. Is it a good thing or a bad thing? I don't know. Now, when you compare it to RFA, so RFA have just limited effect on the tissue just under the catheter. It doesn't have an effect on areas that are deeper to the collagen. To understand why RFA does it, like why in RFA you don't get a deeper effect than the separating layer of collagen, we did an ex vivo experiment when in a bath we put healthy septal myocardium and scarred or border zone myocardium, and we had thermocouples in the tissue. And here I have plotted the intramyocardial temperature in each of those setups. So you can see that in the blue, you can reach significantly in the same distance within the myocardium, you reach higher intramyocardial temperature when you don't have scar. But when you have scar, there is a dump in the maximal temperature that you can reach. So the scar acts as an insulator for heat conduction. Now, with PFA, you don't have it because the effect of pulse field ablation is by applying an electrical field that is irrespective of the material. And this data has been shown by different groups at Gerstenfeld group, our group, and there was a recent paper showing the same thing. And I think the conclusion from these studies is that in contrast to RFA, with PFA, we can target viable myocardium that is separated from the catheter by collagen or fat. So this is an advantage. Now, how is this compared to RFA if we now take newer technologies? Let's say we take this the Sphere 9, which has a large footprint. So here you can see the lesion depth with one application of PFA, 4 application of PFA, obviously deeper lesions. But when you look on RFA, the effect of RFA, this is healthy tissue. So you know you're again not comparing apples to apples, but you get 10 or 11 millimeter depth. Now, is it going to be the same in scar tissue? You know, I don't know. But RFA make really deep lesions with a large footprint catheter, compared to the standard that we use nowadays, which is STSF with a mean depth of 5-6 millimeters. So, from a safety standpoint, there could be some advantages. From an efficacy standpoint, there could be advantage when we are ablating in scar, but there is also potential disadvantages. One is that you have less predictable effect. When you apply PFA, some of it is reversible, some of this is not reversible. The reversibility takes hours. So it's not something that we can predict in the lab. Now, non-inducibility or targeting PVCs and so forth, it is important to get as closer as you can to long-term effects. You don't have it with PFA. The other thing with PFA is not titratable as RFA, so you can make more applications, but you can't really change the dosing so much. The other thing, you have loss of EGMs during ablation, which I don't think it's a great idea. Definitely when you are ablating in VT. And lastly, PFA, or at least the conduction system, is more sensitive to the electrical field than to the thermal field. So when you're around the conduction system in non-ischemic patients, you have to be very careful with PFA. So to come to an end here, I will say, like, PFA is kind of like have been messaged to us as the new king. Maybe. It's not sure. And this is the Gartner hype circle of emerging technologies. And I think, at the beginning you have this hype, and that's, I think, where we were in 2018. I think now the hype is a little bit tempering down when we see that, it's not as safe and not as effective as we thought. And at some point, it's going to plateau. And if this level is going to be higher or lower than RFA, or maybe there's going to be different advantages and disadvantages, it's yet to be seen. So to come to answer this question, will PFA change the results of catheter ablation for VT? I think if I have to guess, I would say likely not. More effective ablation technologies may be helpful. However, these are more influenced by catheter design. So I think large footprint electrodes are going to be more important than the type of energy we use. The real challenge for improving the results of VT ablation procedures is understanding these arrhythmias and identifying the optimal target sites, particularly in patients with non-ischemic cardiomyopathy. And because we are building more destructive tools, we really have to be careful how we use them, not to create more damage than help. And I'll end here. So thank you.
Well, thank you very much. The next talk I have on the program is Dr. Della. Is that? He's in the lab. Is he going to give it from the lab? Or are we moving to the lab? There we are. Oh, Paolo, we don't hear you. We see you, but we don't hear you.
Drug Rhythm Symposium. This afternoon, I will talk about this issue: can VT ablation improve prognosis? Actually, in the last years, large retrospective studies have suggested the survival benefit of an effective ablation of ventricular tachycardia, but data from randomized prospective studies to support these findings were still missing due to issues in study methods that affected feasibility. I think that the most interesting data is stemming from this big database originated from this IVTCC study, analyzing data of more than 2,000 patients that had undergone ablation for VT in the setting of structural heart disease. The slide clearly shows that among these patients, those that did not suffer of VT recurrence following the ablation had a much more favorable follow-up, the endpoint being mortality and freedom from cardiac transplant. And you can see on the upper right corner that this is particularly evident in patients with depressed ejection fraction. Now, data from prospective studies in these last years have mostly focused on the concept of prophylactic VT ablation, and most of these studies, although having shown reduced recurrence rate of VT, failed to prove a survival benefit. You see here that we gathered the studies according to the timing of the ablation with respect to the occurrence of VTs, and we have on the left the studies on prophylactic VT ablation, early VT ablation following the first ICD shocks, and late VT ablation on the right. Today, I will analyze with you the data originated from the recently published studies in years 2022, post-SCD, Survive VT, and Partita study. Post-SCD trial is unique in its patient population, as it gathers the majority of patients with non-ischemic cardiomyopathy and namely right-sided arrhythmogenic cardiomyopathy. It analyzes the follow-up of 120 patients randomized following ICD implantation to catheter ablation of medical therapy. As you can see here, baseline ejection fraction was pretty high in all the groups, so this is really making pretty difficult to analyze the presence of any survival benefit. This study is interesting as it shows the use of advanced mapping techniques, as you see here, multi-electrode mapping, detailed analysis of the propagation map during sinus rhythm, so profound analysis of the substrate during sinus rhythm. The endpoint included non-inducibility of the target VT. Among the weak points, however, we see that remapping, although being encouraged, to assess modification was not really mandatory, and complete non-inducibility was not mandatory in this study. With that in mind, we see that freedom from VT recurrence, cardiovascular hospitalization, and death was successfully reached in the study, as it was significantly lower among these patients that underwent ablation. The major benefit, however, being offered by the prevention of VT recurrence as freedom from further hospitalization and from cardiac death was actually non-affected by catheter ablation. The second interesting studies that I'm willing to present to you is the SURVIVE-VT study that also has been published by the Spanish group, first named Dr. Arenal, last year. Is a study that is mostly focused on patients that had suffered from a prior infarct. 140 patients were randomized to catheter ablation or anti-drug treatment. Average ejection fraction 40 to 35% in this group. And I think that among the features that are included in these studies is that VT induction was not required to guide ablation. So it's a subset modification study, mostly guided by imaging, pointing to the elimination of abnormal electrograms. Again, this has been a successful study that showed that patients that underwent ablation reduced the composite endpoint of cardiovascular death, appropriate ICD shocks, hospitalization due to heart failure, or severe treatment-related complications. Why do I think this is an interesting study? Because it actually does affect prognosis. Although cardiovascular death is seemingly unaffected, as it is hospitalization for heart failure, I think that the most interesting finding of these studies is described in the panel D, treatment-related adverse events. Patients that were treated with drugs had an impressive series of recurrent hospitalization due to slow VT that actually required almost invariably ablation. So these were patients that were initially randomized to drug treatment. And it really shows the downside of a treatment-based treatment that actually affect prognosis, as you see here. Drug interruption or hospitalization for further treatments is extremely more frequent as opposed to patients that had ablation. The third study that I am willing to show you is the Partita study that actually is published by our group. This study was designed to verify the prognostic impact of early VT ablation after the first ICD shocks on the endpoints of mortality and worsening heart failure, and also to provide data on natural history of VT following ICD implantation, trying to identify a specific arrhythmia pattern that might predict a subsequent shock. It was a multi-center randomized controlled two-stage study that took more than 10 years to be concluded. Also very important, as you will see, follow-up was daily performed by home monitoring. The first stage, we call it phase A, included evaluation of the rhythm features of the patient from enrollment to the first ICD shock. Patients were included for both primary and secondary prevention in both ischemic, post-infarct, and non-ischemic dilated cardiomyopathy. Aim of the phase A study was to verify whether the burden of non-sustained or ATP-treated sustained VT was predictive of subsequent shock. The second phase, phase B, started from the first appropriate shock, where patients were randomized to a group 1 immediate catheter ablation of the ventricular tachycardia or standard treatment, ablation being performed after first episode of electrical storm whenever it occurred. So the study primary endpoints were first appropriate shock delivered for VT, the phase A, and for phase B, a composite of death from any cause or worsening heart failure that led to a subsequent hospitalization. Secondary endpoints, cardiac mortality, recurrence of sustained VT, appropriate shock therapy, and electrical storm. Now, the study was powered to prove advantage in the ablation arm according to the incidence of shock gathered from prior studies. That was 20% in 5 years in the primary prevention group and 53% in 2 years in the secondary prevention group, leading to a lambda shock incidence per month of 0.4 in the primary prevention and 3.1 in the secondary prevention group. But actually, what we observed was a much lower incidence of shocks. Actually, numbers were 0.3% of shock incidence per month in both the primary and the secondary arm. Why that? Possible reasons for lower shock rate were mainly related to ICD programming. This study was published after the milestone MEDIT-RED studies. So longer detection times and therapy set at higher rates of VTs and drug. Home monitoring allowing a quick, rapid up titration of beta blockers whenever episode of VT had occurred. And amiodarone was substantially banned, so reduced risk of pro-arrhythmias. As you see here, patients were not treated if their VT rate was lower than 167, so that was within the monitor rate. And if the VT was occurring at a rate higher than 167 up to 200, we had a very long detection and redetection counter, approximately leading to a 20-second delay before any ATP was delivered. So really this allowing an extensive evaluation of non-sustained episodes or ATP-treated episodes. As a lower than expected percentage of patients experience VT, we really thought that the study would have been unrealistically prolonged. So the clinical investigation plan was quickly amended to include an adaptive design to a randomized study using a Bayesian approach, and 2 interim analyses were planned at rates of 25 and 50% of the projected sample size for phase B. Actually, by July 2021, the number of randomized patients required for the first interim analysis completed the study and enrollment, and the analysis showed that the predictive probability of success was higher than the protocol-specific boundary of 99%, so that allowed an immediate claim of study success. There is superiority of immediate ablation over standard treatment. Now, let's see in detail what happened to our patient. Among the 570 patients that were randomized, overall 246 experienced any VT, 47.6%. Of these, 28% being non-sustained to the long detection timing of the ICD programming. Sustained VT being documented in 154, which is about 29.8% of the study population, with 62 patients being treated only with ATP and 56 patients treated with shock and ATP and shocks. Patients that went on to shock were more likely suffered from a prior myocardial infarct. And more importantly, we found that among the arrhythmia findings, the number of non-sustained VT episodes were non-prognostic, whereas the number of VT treated and eventually terminated by ATP was actually very important, as any ATP run that terminated AVT was associated to a 4% higher rate of subsequent shock. Among the 56 patients that received an appropriate shock for VT, 9 were not randomized because either refused randomization, 2 died, 1 had first occurrence of electrical storm, and 47 were randomized, 23 contributing to the intention to treat analysis set of the ablation group, and 24 to the ITT analysis set for the standard therapy arm. You see here that patient that went on to ablation was slightly, although not significantly older, 71 versus 65 years. Both groups had a pretty much depressed ejection fraction, 31 versus 32%. Primary prevention, 70-30, ischemic versus non-ischemic, 80-20%. This slide details the requirements of the ablation protocol. High-density mapping was strictly enforced to gather both voltage and activation maps, as you see here. VT activation mapping to VT termination was mandated strictly in all patients, as it was remapping that had to show, as you see here, lower left corner, complete abolition of any abnormal activity. Once this endpoint was proven, patient went on to have program stimulation with 4 extra stimulus, and that had to show the complete non-inducibility of any VT. Now let's go to the results of phase B. The composite endpoint of all-cause mortality and worsening heart failure occurred to a significantly lower extent in the ablation arm, 4% versus standard therapy arm, 10 patients, that is 41%. There was no mortality in the patient treated with ablation, 8 versus 8% in the standard therapy. Worsening heart failure and cardiac mortality 6-fold higher in the patient treated with standard therapy as opposed to ablation. Among the secondary endpoints, recurrent VT with shock, 8% in the ablation arm, 41% in the standard therapy arm. The slide here shows the Kaplan-Meier analysis of the primary endpoint, both in the intention to treat analysis panel A and the per protocol that really in panel B, that really shows how important is the difference in the outcome of the primary endpoint between the ablation and the conservative standard therapy arm. Also, you see here, panel C, that there was no mortality in the ablation arm, and worsening heart failure hospitalization contributing also to a minor extent to the endpoint of the study. Among the secondary endpoints, I think it is very important to point out the difference in recurrence of ventricular tachycardia treated with shock between the group. And that is very important because that leads to Partita being the first trial to really confirm the link between decreasing arrhythmia recurrence and enhanced survival. It is very nice to show the similarity of the two survival curves of the retrospective IVTT study on the left, where patients that had no recurrence following VT ablation had a significantly lower incidence of mortality and requirement of transplant, panel on the left, and on the right, the overall event-free survival, again, I remind you, overall mortality and worsening heart failure mortality among patients that were treated by ablation, red line, versus those that treated by standard therapy. So we see that despite the limited sample size, the Partita trial indicated a significant superiority of VT ablation after the first episode of VT treated with shock over a standard approach in terms of both mortality and hospitalization to worsening heart failure. The composite endpoint of that and worsening heart failure was 4% in the ablation group versus 41% in the control group, with a relative risk reduction of 89%. Also, catheter ablation was associated with lower recurrence of VTs treated by shock and with a lower mortality. So overall, this finding support for considering ablation in patients with ischemic or non-ischemic cardiomyopathy, both in primary and secondary prevention indication for ICD after the first appropriate shock. Among the relevant observations stemming from the study, also we observed a lower than expected rate of VT treated with shock. Now in the years 2020, approximately 10% at 3 years in both primary and secondary prevention, much lower than historical data stemming from studies published in the years 2000. And that was probably related to multiple reasons. Study core characteristics, prompt uptitration of beta blockers during remote monitoring, avoidance of amiodarone treatment, and modern ICD programming and anti-tachycardia pacing efficacy. Also, considering ATP, any ATP leading to VT termination was found to be a strong predictor of subsequent ICD shock. Actually, any successful delivered ATP increased the risk for subsequent shock by 4%. Now my final slide. Does ablation of VT affect prognosis? Yes. I think that these 3 last studies that have been published last year are altogether pointing in the same direction. There is a strong benefit in the primary endpoint that includes death, heart failure, treatment-related complication, evidence of hospitalization stemming from these 3 studies, and that for me constitutes a strong call for immediate treatment of ventricular tachycardia, kind of early in the natural history of the patient following ICD implantation. Thank you for your attention.
We will now move to the discussion questions for Dr. Garcia, Dr. Anter, and Dr. Della.
Federico, maybe.
All right, do we have all of our panelists available for a question. We see Dr. Della.
Well, but still, here.
Yeah, the one was...
Questions?
Oh, we need to... Oh.
Paolo, are you available for questions?
Yeah.
We see you, but we don't hear you.
Hello, this is Elad. I can. Hello. Hello.
Ah, very good. Okay. So questions for Dr. Garcia and Dr. Anter.
Try again once, please. One more. One last run, please. Okay.
Very good. So Fermin, let me ask you, you showed that the endocardial activation timing can be very misleading for these LV outflow tract arrhythmias. But is there a downside to going to just the earliest endocardial site and giving an RF application there first before you do all of the other mapping? What has led you to your present approach?
Yeah, I think that that's a very good point, Bill. I think that retrospectively, if you think about it, if you don't find anything early after mapping everywhere, and then you go to the earliest endocardial site, even though it could even be post-QRS, that would be the findings of the true intramural success PVCs that we did when it was really early. So I think that the first thing you do is you rule out an epicardial LV summit, defined LV summit origin, because it's not minus 40 in the AAV. And then you don't have anything really early anywhere else. If you could not get, and that strategy could help even if you're prepared to do venous mapping. Sometimes there's no veins. Sometimes you do a good venogram and you don't find any veins that you can put a wire or anything. So that would be a strategy that you can approach and try to do a lesion from the LV endo to see if you have any effect. So absolutely, you could do a relatively earliest breakthrough in the endo, even if it's late, and go there to give it a shot, quote unquote.
Thank you.
I like to see it early first, because then I know that what I'm doing, even though it doesn't make sense because it's late, it's going to work because you're so close. So I like to prove the concept that's early in the intramural space. But if you can't for any reason, that would be a strategy, and you would know, because if you're close enough, it's going to work. It's going to work within the first few seconds of RF application. If it takes you a minute to suppress the PVC, then you know you're very far away, and that might not get you anywhere.
Speaking, I have a question for Professor Anter, if it's possible. May you hear me?
Yes.
Okay. So, of course, I know that we are in another field, but just talking about PFA, what do you think about the recent report about the complication with the intraparenchymal hemorrhage in the lung? So, considering the safety, okay, and considering the neighbor, so the structure that are just close to the heart, what do you think about it? What you can say about it?
About the lungs specifically, or about the safety profile of PFA in general?
Because I agree with your conclusion. So I think that we are just in the beginning, in an early phase of experience with this new energy.
Yeah. Again, as I mentioned before, when PFA was first reported clinically by intravenous catheters or percutaneous procedures, the safety profile seems too good to be true, but seems very, very promising. I think for atrial fibrillation ablation, there is no doubt. There is already, as Joseph showed before, there is over 10,000 cases. There is no esophageal injury. It's safe for atrial fibrillation in the sense of protecting the esophagus, which is the worst complication. And it looks like also phrenic nerve, it does not cause any permanent damage. It can cause some transient effect. So we started from no effect on the phrenic nerve. Now potentially there is an effect, but it's transient. The coronary arteries, we know there could be an issue. The lungs, we know there could be an issue. Is it like the result of first iteration technologies, or is it really the energy itself, yet to be discovered? I don't know. I really don't know what's the answer to what you're asking. I think we need more experience, particularly like for VT. Is it really an appealing technology versus RFA? I don't know.
Thank you.
Thank you very much. So should we move to the cases? Are you guys ready to?
We're going to be ready soon. Okay.
It looks like Dr. Della may be ready.
Okay.
Should we move to the case or should we do more questions?